So when we are talking about the stomach and duodenum, then the most important causes, especially in terms of the duodenal ulcers or the duodenal duodenal erosions, will be the H. pylori infection. H. pylori infection. Helicobacter pylori infection is one of the most important cause of the duodenal ulcer or the duodenal gastritis, duodenal erosions. And in terms of the stomach, the most important reason along with H. pylori will be NSAID. In both of these situations, non-steroidal anti-inflammatory drugs do cause this duodenal and the gastric ulceration and erosions. So what's the role of the non-steroidal anti-inflammatory drugs? They actually, NSAIDs, they inhibit cyclooxygenase. Which decreases the production of prostaglandins. So the inhibition of the cyclooxygenase decreases the prostaglandins production. So as a result of all of this, there is increased acidity or the decrease in the mucosal protection. When the mucosa is no more being protected by these prostaglandins, then there is a gastric ulcers and gastric erosions. So one of in the etiology, another very important role is of the H. pylori infection, and then there is no use of non-steroidal anti-inflammatory drugs, and the most important can be aspirin, because so many patients in their older ages are actually being prescribed aspirin, which is a very famous anti-inflammatory non-steroidal anti-inflammatory drug. So this can be a reason of the this gastric ulceration and the duodenal ulceration. But in the duodenal ulceration, the major role is that of a Helicobacter pylori infection. So when we talk about the etiologies of the upper GI bleed, we have seen that there can be esophageal involvement in the esophageal varices. There can be H. pylori infection in the duodenum and the stomach. There can be non-steroidal anti-inflammatory drug used in both the duodenal and the gastric ulceration. So what else can be the reason of this upper GI bleed? Then there are stress ulcers or stress gastritis. Stress ulceration. Stress ulcers are the one which are because of the increased gastrin or hydrogen ion release in the stomach, and it happens in many cases, but most famous are the burns. Those patients who have got burns, they develop the stress ulceration, and this is known as Curling's ulcers. Curling's ulcers. Now, along with this group of the patient, another very important group of the patient are those who have road traffic accidents, and they are patients of head injuries. In these patients, because of the increase in the intracranial pressure, there are ulceration in the stomach, which we call the stress ulcers, and in this particular type of the patient, it is known as Cushing's ulcers. Cushing's ulcers. So along with esophageal varices and NSAID use, H. pylori infection, These stress gastritis or stress ulceration is very important in cases of the burns case. It is known as the Curling's ulcer, and in cases of the road traffic accident and the head injuries, this is known as Cushing's ulcers. Then those patients who have gastrinoma. Now we are talking about the etiologies which are not that prevalent, or their incidence and prevalence is less as compared to the one we have already talked about. There can be an increase in the release of the gastrin in situation of the gastrinoma. This can be a reason of the a lot of ulceration in the stomach, which ultimately oozes and causes the upper GI bleed. Then there can be vascular anomalies like the angiodysplasias. Angiodysplasias are one very famous example, but though rare in their prevalence and the incidence. So these are the vascular malformations. So the gastrinoma, angiodysplasias, these are other causes of the upper GI bleed. So this is about the etiology. Now we have seen the presentation of these patients, and we have seen the etiology of the upper GI bleed. So what is the how we diagnose these patients? Diagnosis. So the first thing is history. History is pointing towards the problem of the upper GI bleed, like hematemesis, melena, hematochezia, so there can be, along with this, there can be some signs of decompensated liver disease. Decompensated liver disease are the signs of portal hypertension. For example, ascites, splenomegaly, caput medusae, spider angiomata, telangiectasia. So, and obviously there can be jaundice. So on the history and physical examination, you do find some points which are actually pointing towards the presence of the problem of the upper GI bleed. For example, patient can give the history of the hematemesis, or the vomiting of the blood, black tarry stool, bright red stools, or the fresh blood in the stool. There can be certain signs of decompensated liver disease. If you see a patient which has got a protuberant abdomen and has a caput medusae, and there is a splenomegaly at least 5 centimeter below the costal margin, there are some prominent veins all around the umbilicus caput medusae, and there are certain spider-like red streaks going away from one central focus, which is spider angiomata, and there can be telangiectasia again, looking bright red colored streak. So history and the physical examination does point towards a diagnosis of it, or at least suspicion of it. Then you can actually do the now there are depends upon the presentation of the patient. If this is a milder presentation, then you can wait to get complete blood count to see if the level of the platelets is less in cases of the decompensated liver disease patient, because platelets are less because of the splenomegaly. Splenomegaly is a very important feature of the portal hypertension, and it does cause thrombocytopenia. So in the complete blood count, HB or the hemoglobin may be on the lower side, because either the patient may be profusely bleeding, or patient may be bleeding for a longer period of time, and as a result of it, patient's blood hemoglobin drops to most of the time less than 8 milligram per deciliter. 8 gram per deciliter. So there may be anemia. you obtain the patient CBC. You may also obtain the patient's chest X-ray. Chest X-ray. So the chest X-ray can show some sort of aspiration pneumonia. If the patient is not you can say the conscious level of the patient is not good, then there are chances that when the patient is having vomiting of the blood, he or she would have aspirated some material. So chest X-ray can show some aspiration, and it can also give some history of the cardiomegaly, because those patients who have got some concurrent cardiac problem, they are most of the time on the aspirin, and that will also point towards the NSAID use, which is a reason of these problem of the upper GI bleed. So looking at the X-ray can give a lot of manifestation of the heart problem. Cardiomegaly can be there in cases of the ischemic cardiomyopathy issue. Cardiomegaly because of ischemic cardiomyopathy. So along with the chest X-ray, we should also obtain ECG, electrocardiogram, because ECG will again can show two things. One, ongoing cardiac ischemia, because either the patient's hemoglobin has dropped so dramatically that now it's compromising the supply of the blood to the heart, and patient was a borderline case of heart problem, and now the patient again developed some cardiac problem. So there may be an ongoing cardiac ischemia. On the ECG, there can be old myocardial infarction, because there can be pathological Q wave present, or there can be any arrhythmia because of the stress and increased adrenergic activity. Why it is important to have an ECG and to have some idea of the heart issue, which may be either in the past or the patient is having currently, because the management can be affected by the presence or absence of the heart issue. Because when we are to talk about the further management of these patients, and we are to go for the endoscopy, then the hemodynamic stability and presence or absence of ongoing cardiac problem becomes very important from that point of view. So ECG is very important. So we have received this patient, and it depends actually what is the condition of the patient. Now here we have talked that patient is relatively stable, is giving a history of hematemesis or melena. So the management follows the diagnosis or follows a certain period of stability of the patient, and during that period of stability we have obtained these tests. So CBC, chest X-ray, ECG, blood grouping and cross matching, because these patients most of the time have their hemoglobin dropped to less than 8 gram per deciliter. So we should have in our hand the blood group and cross match in those cases where we may need to transfuse these patients with the blood transfusion. Blood grouping and cross matching. Blood grouping and cross matching, because it may happen that patient is unstable and you haven't got the blood group of the patient. So how can you arrange the blood for these patients who definitely need the blood transfusion, because that will become a huge problem at that very time when it is a panic around everywhere. So CBC, chest X-ray, ECG, blood grouping and cross matching, and if possible and the patient is stable enough, we should also obtain ultrasound abdomen to look at the liver of the patient, because in case of the decompensated liver disease, patient may have signs of cirrhosis. There can be splenomegaly, and there can be all other signs of portal hypertension like the ascites on the ultrasound examination of this patient. So these are almost kind of a test we should obtain in these patients who have come in emergency department or ICU, and they had milder symptom of hematemesis, melena, hematochezia, these kind of things. But the test of choice, but the one test which helps to diagnose the upper GI bleed is endoscopy. Endoscopy is the test of choice to not only diagnose but also manage, but it pinpoints the presence of or the location of the source of the upper GI bleed. So that is the endoscopy. So this comes in the diagnosis. So this is one of the important diagnostic tool. We get the endoscopy of the patient. This is also known as EGD, esophago gastro duodenoscopy, because here we see the esophagus, the gastrum or the stomach, and the duodenum, second part of the duodenum. We can go all the way up to the location of the ligament of the triads, and we can look with the help of the camera the presence or absence of the source of the bleeding. So this is how we do the esophago-gastroduodenoscopy, that we look at esophagus, then we look at the stomach, then we look at through the pyloric sphincter we enter into the duodenum, first part and second part of the duodenum. So we can localize the source of the bleeding up till the ligament of the triads, and this is what we call esophago-gastroduodenoscopy. This is the test of choice, procedure of choice to diagnose the source of upper GI bleed. So once the patient is diagnosed, then how the patient is managed? The management of upper GI bleeding depends upon the hemodynamic stability and the rapidity of the bleeding from the source. So the management of these patients starts from management. Okay, another very important test which we should obtain for these patients in the diagnosis is urea and creatinine plus PT-APTT-INR. PT-APTT-INR. These two are very important tests when we are to talk about the diagnosis of a patient of upper GI bleed. Then we need to get urea and creatinine and PT and APTT and INR, because in case of the urea and creatinine, those patients who present with the upper GI bleed, in them urea is may be very high, and creatinine may be within the normal range. That also shows that there is an ongoing upper GI bleed. Secondly, looking at the PT, APTT and INR, in those patients, especially who are cases of the decompensated liver disease, they have got a deranged PT, APTT, INR, because PT and INR, they show us the status of the liver. INR is international normalized ratio. It should be less than 1.2. But if it is more than that, that means clotting factors are not being formed. And if the patient was on the anticoagulant like the heparin, then we need to monitor the APTT, because it affects the spoiled limb of the coagulation. So we need to obtain these tests in the diagnosis of the patient. How we manage these patients? First of all, always remember, especially in these cases which come with a suspicion of upper GI bleed, always try to follow the ABC: airway, breathing, circulation, or hemodynamic stability. Hemodynamic stability of these patients is very important. Airway, breathing, and circulation. Why we need to take care of the airway? Because, as I already mentioned, if the patient is not the case of the stomach ulcers or the duodenal ulcer, then the source may be the esophageal varices. And esophageal varices occurs in cases of the decompensated liver disease, which may be brought to the hospital in hepatic encephalopathy. And if their conscious level is compromised and they are also throwing up the blood, then chances are that patient can aspirate that blood down to their lungs. So we need to maintain the airway. If the patient's conscious level is down, if the patient's Glasgow Coma scale is less than 9 by 15, better we intubate the patient. We pass the ETT, so aspiration of the gastric contents or the blood down to the lungs can be avoided. So maintaining an airway is very important, but if the patient's conscious level is better than this, our patient is able to protect his or her airway, we do not need to pass the endotracheal tube. So maintaining airway patency is very important in these patients. Then comes the breathing. Again, we are to look at the breathing pattern of the patient. If the patient is breathing normally, if the patient is tachypneic or dyspneic, if there is a labored breathing, we auscultate the patient chest. And if on the auscultation we find that the patient has already actually aspirated the gastric contents, then chances are that this patient may be in tachypnea. Their respiratory rate may be on the higher side, say it may be 24 per minute, and ultimately patient has the risk of being exhausted, and we may lose the patient, because once exhausted, patient will very rapidly develop metabolic acidosis or the respiratory acidosis, and then there can be a problem. So if on auscultation there are conductive sounds and we think the patient has already aspirated the gastric contents, again we may need to pass endotracheal tube after a little bit explanation to the patient, rather than losing the patient after half hour, because the patient may crash if we not manage properly. So we can auscultate and take care of the breathing and follow the saturation of the patient. SpO2, we need to maintain it more than 95%. If the saturation of the patient is less than 95, we will put the patient on the oxygen, and if it is not improving and there are chances of the aspiration of the gastric contents into the lungs, we may need to intubate the patient. So after the breathing comes the C portion, which is the circulation. Circulation is actually again very important, because circulation will tell us about the pulse and the heart, pulse and the blood pressure. Pulse and the blood pressure. Okay. Pulse may be normal, may be tachycardic, and the blood pressure may be normal or more than 100 millimeter of mercury systolic or less than 100 millimeter of mercury systolic. This is very important, because let's talk about a little bit about the loss of the blood. In those patients who present to the emergency department with a complaint of massive bleeding through the vomiting, and in those patients, there are certain categories. If the patient loses like around 750 ml of the blood, patient is in the stage 1 of the blood loss. So, and if patient has a loss of 750 to 1500 ml, patient is in the second stage of the blood loss. Patient may have lost 1500 ml to 2000 ml. Patient is in the third category of the blood loss, or patient can be have lost more than 2000 ml or 2 liter of the blood by vomiting out the blood or through the stool. Then patient is in the fourth category of the blood loss. So in these patients who are in the first and second category, chances are that patient's pulse can be normal and the blood pressure may be more than 100 systolic. But in the second and the third phases, where the blood loss is more than 20% of their body, then these patients go into the tachycardia and their blood pressure is less than 100 millimeter of mercury, 100 millimeter of mercury systolic, not milligram but mercury. So they are hemodynamically unstable. and the urgency of their management will be dictated by these things. So the HB level initially may not be low because it will only lower once the patient is given certain fluids, because of the loss of the blood. Patient is not only losing the hemoglobin but also the serum, so hemoglobin level does not fall that significantly. But we are to follow the pulse and the blood pressure of these patients. If the blood loss is more than 2 liter, or is more than 20% of the blood has been lost from the body, then patient may be having a blood pressure of less than 100 by 50 or 60 millimeter of mercury, and patient may be tachycardic. Patient may be having tachypnea, because these patients drop their saturations and they are trying to catch the air. So the ABC of these patients is very important, and after we have resuscitated the patient or assessed the patient for the resuscitation, that the loss of the blood seems more, because these patients' skin can be sweaty, it can be cold because of the hyperadrenergic system being activated. So we are to pass at least 216 bore IV lines. In those patients which fall in the category of more than or around 20% of the blood loss, they have got cold clammy skin, they are tachycardic, their pulse is feeble. So we need to pass 216 bore IV lines. So as a part of management, one very important thing is pass to large bore IV granulas. IV granulas. Preferably it should be 16 gauge. Not less than 18 gauge, not more than 18 gauge. Try to pass a 16 gauge IV line, and it should be two on either side. Try to pass central venous pressure line if possible. Try to pass central venous pressure line if possible, because it depends upon the conditions of the patient. If patient is hemodynamically or otherwise is not stable and you need to put endotracheal tube, you cannot waste your time to pass central line before taking on those measures. We have passed either to large bore IV line granula, which are a must, not either, and we may pass and we may not be able to pass the central line, because if we have passed it, it's good, because we are to maintain it around like 8 to 10 centimeter of the water for the hydration of the patient. Now, obviously, these patients have lost the blood, so they are dehydrated. And if we do not find a contraindication, like the patient being in the volume overload, in those cases where patient have got the concurrent myocardial infarction went into the pulmonary edema, but in majority of the cases, it doesn't happen. These patients, they are volume depleted. The rule is that we are to replace 1 ml of the blood with 3 ml of the crystalloid. So the fluid of choice in these patients of the upper GI bleed who we received in the emergency department is actually crystalloid, which is either normal saline 0.9%, or it can be lactated ringer or ringer lactate. Lactated ringer or ringer lactate. For example, if we assess that patient has lost 1000 ml or 1 liter of the blood, then we are to give 3 times this blood loss, like 3000 ml or 3 liter of the crystalloid fluid. But if we are to use colloid, then do not go for the 20% albumin, use only the 5% albumin, because that will be easy to administer and that will have a greater effect actually. But try to restrict yourself to the crystalloid use in the very beginning part of the management of the upper GI bleed patient, because they are hemodynamically unstable. You are to immediately pass at least 2 IV granulas of the large 16 gauge and if 16 is not available, you can go for the 18 gauge, but avoid going less than 18, because that can not help. Because from the Poison's law, we know that the flow will be inversely related with the length and directly related with the fourth power of the radius. So if the prenula is has got a larger diameter and shorter length, then it will be beneficial for the flow of the fluid which we will be giving, or the flow of the blood which we will be giving to resuscitate the patient. Because in the very few hours or few minutes of the patients being received in the emergency department, there is no arrangement of the blood available for the patient, so we are to use crystallide, where 1 ml blood loss will be replaced with at least 3 ml of the crystallide, and should be given by the larger bore granulas like the 16 gauge. So then we try to maintain the patient's hemodynamics. We continuously monitor the blood pressure and the pulse and urine output. In the management, another very important part is to continuously pass Foley's catheter to monitor the urine output. Monitor pulse, blood pressure every 10 minutes. Try to put the patient on the cardiac monitor. There will be a continuous display of the pulse and the blood pressure. Target is to maintain the blood pressure more than 100 millimeter of mercury systolic. Pass Foley's catheter. Pass Foley's catheter to monitor urine output. This is again a very important aspect which is neglected in majority of the cases, to monitor urine output hourly, on hourly basis. And try to keep the urine output more than 0.5 ml or at least 0.5 ml per kg per hour. If it is less than this, there may either be the under resuscitation of the patient with the fluids, or the renal function of the patient may be compromised before this event. Try to get hemoglobin level. Check hemoglobin 2 to 4 hourly. This is again very important. Check hemoglobin level 2 to 4 hourly. And now patient is the source of the bleeding at this point in time may not be evident. Patient may be bleeding either from the esophagus, from the esophageal varices, or patient may be bleeding from the gastric or duodenal ulcer. So at this point in time, where we have not done the endoscopy and we do not know the source of the bleeding, we are to cover both of these problems. For example, for duodenal ulcer and the gastric ulcer, we are to start PPIs, proton pump inhibitor, because these proton pump inhibitor, they act on the hydrogen, potassium, ATPase, hydrogen potassium ATPase, and they decrease the excretion of the hydrogen ion in the stomach, and in this way they increase the pH more than 6. They increase the pH and they maintain the pH more than 6. So we give proton pump inhibitors. They inhibit the hydrogen potassium ATPase receptor in the stomach, and they keep the pH of the stomach more than 6. They do not make it more acidic, but they make it more alkaline in pH. So that helps in slowing down the ooze of the blood, or the source of the bleeding is actually helped to make the clot. So the famous are, here in Pakistan we use omeprazole. We can use S-omeprazole. We can use lansoprazole, and we can also use pantoprazole. H2 blocker are not very effective in these situations. Histamine 2 receptor blocker are not very effective, so we use proton pump inhibitor which inhibit the hydrogen potassium ATPase. We use omeprazole, esomeprazole, lansoprazole, pantoprazole, because this use of the PPI will cover this part of the source of the bleeding. Gastric and the duodenal ulcers will be covered by this because they are exacerbated by the acidity of the stomach, which is decreased by the use of proton pump inhibitor. How we use, for example, omeprazole? We give 80 milligram IV bolus in 1 hour. So how we use omeprazole? Omeprazole, which comes with the brand name of Ryzik. So, but there are so many others. We give 80 milligram IV in 100 ml normal saline in 1 hour. And after we have given this loading dose, then we start the patient with infusion of 8 milligram per hour. So we can dilute 1 injection or 2 injection of the Ryzik in 50 ml of normal saline, and we can infuse through the infusion pump at 5 ml per hour, which will be 8 mg per hour. So we keep on giving for like the coming 2 or 3 days or 48 to 72 hours till the time either we are very sure of the diagnosis that it was indeed an esophageal varices and not the gastric source after endoscopy, or the bleeding has stopped, and then we can put the patient on the oral medications of the PPI or the proton pump inhibitors. So along with monitoring of the pulse, blood pressure, and resuscitating the patient with the crystallite fluid, giving 3 ml for each 1 ml loss of the blood, and we will pass the Foley's catheter to monitor the urine output. It should be monitored. Urine output should be monitored 1 hourly, because we want the patient to pass at least or more than 0.5 ml per kg per hour. And then the hemoglobin level is checked every 2 to 4 hourly. And along with it, we are to arrange for the patient's blood. We are to get the patient's blood grouping and cross matching. We are to arrange whole blood. Another very important point which should be remembered at this point in time: do not arrange packed cell volume as long as there is not severe contraindication or absolute contraindication to its use, because packed cell volume are the worst form of the blood for the resuscitation. They will take a long time to be transfused, while the whole blood, which contains the serum, hemoglobin, and all the clotting factors, will be very fastly given to the patient to resuscitate the patient. So we are to check hemoglobin at every 2 to 4 hourly. We are to maintain the hemoglobin more than 8 gram per deciliter normally, but in case of the cardiac patient, we are to maintain it more than 10 gram per deciliter. And as long as we haven't been able to arrange the blood, we are to use crystallite to at least fill the intravascular space with the fluid. And once the blood is arranged, we can then manage it this way that we will give the blood and stop the fluid. And at this point in time, we are not sure about the source of the bleeding, so we will cover both the gastric and the duodenal ulcer and esophageal varices. So for gastric and duodenal ulcer, we will use omeprazole. We will inject 80 milligram in 100 ml normal saline in 1 hour as a loading dose, and later on we will put the patient on infusion of 8 milligram per hour for at least 48 to 72 hours. 48 to 72 hours. In the meantime, we will do the endoscopy, and once sure of the abscess of this part of the etiology, we can stop or put the patient on the lower doses of the oral medication of PPI. But if we know that the source of the bleeding was indeed the gastric or duodenal, then we can switch after 72 hours to the oral medications. But for as long as patient has got the source, we will keep on giving the IV infusion form. Now, another step is to do something for the esophageal varices. What we do here, this is what's happening before the endoscopy is being arranged and the blood transfusion is going on or being arranged. So the next thing will be to give the either octreotide or terlipressin. These are the vasoconstrictors which try to stop the which try to constrict the dilated veins in the esophagus. We give octreotide. This is an orphan indication, orphan use of the drug. This is not prescribed by the FDA or other bodies, but octreotide is used to stop the bleeding of the esophageal varices, and we give 100 microgram IV stat or the bolus form, and then we infuse it 50 microgram per hour. So 100 microgram or 0.1 milligram is given in IV bolus form, and then 50 microgram or 0.05 mg per hour infusion is started to vasoconstrict the esophageal varices. So as long as we haven't done the endoscopy, we'll just keep on giving this infusion. The second option is vasopressin analog, which is terlipressin. This is a vasopressin analog, and we give it in a dosage form of 2 milligram IV 4 to 6 hourly. It's a very strong vasoconstrictor, and a second thought should be given in those patients who are known cases of ischemic cardiac disease or ischemic problem with the heart. So because it causes the generalized vasoconstriction, then there can be a problem with the cardiac function of the patient. So terlipressin is a vasopressor analog and is given initially in the 2 milligram IV 4 to 6 hourly. Then after 24 hours, it can be downscaled to 1 milligram IV 4 to 6 hourly. This is again very important and very famous drug. Now, when we are doing these kind of management, we are to surely stop the NSAID. Stop NSAID. So those patients who are either hemodynamically unstable, they need to be resuscitated before attempting the endoscopy, because the last and the final and the most important part of the treatment of the upper GI bleed is endoscopy or the EGD. This is not only the diagnostic modality, it's also therapeutic one. So as a last part of the management of the upper GI bleed, we go for EGD or endoscopy. And we briefly say we scope the patient. So there may be early endoscopy, there may be delayed endoscopy. Early and delayed endoscopy. Early endoscopy is performed within the first 24 hours. Early is performed in less than 24 hours of the presentation of the patient. If the patient had a profuse bleeding, patient will be resuscitated initially. Then we will manage to arrange the endoscopy, and after we have even consulted a general surgeon, because a general surgeon should be handy, because one of the major source of the bleeding can be gastric carcinoma. Gastric carcinoma, or in case of the Boer-Haave syndrome, patient may have esophageal rupture, or in case of the aortoenteric fistula, we need to have a surgeon around. We may need laparotomy, and we should talk to the patient and the family about these factors. And even because of as a complication of the endoscopy, we can overburn the tissue of the stomach or the duodenum and cause the perforation as a complication of the endoscopy. So we should have a general surgeon at hand, because as a last resort we may need the surgery of this patient, which we are managing as a case of upper GI bleed. General surgeon should be handy. So what we do in the early endoscopy, we perform the endoscopy within the first 24 hours. And in case of the delayed, we can perform it after 24 hours, and we can do it electively. So what we do in the endoscopy, that we pass the scope or tube having a camera. So first it goes into the esophagus and try to localize the source of bleeding there, which can be esophageal varices, which can be tear in the Mallory-Weiss syndrome, which can be Boyer-Have syndrome, and there can be a rupture of the esophagus, and there can be esophagitis and erosions of the esophagitis. So if localized, then with the help of the same endoscopy, we can either ligate it, or we can put some clips of the esophageal varices. Ligation or the clipping can be done. So we actually put the ligation around the neck of the esophageal varices to stop the source of the bleeding. So we have so oftenly heard the name EVD. So esophageal varices can be either ligated or clipping can be done. So this is a EVL, esophageal varices ligation, or EVBL, esophageal varices band ligation. So band ligation is done or clipping is done. We can also inject these patients through the endoscope with adrenaline. Injection adrenaline in 1/10,000 strength to arrest the bleeding temporarily, so we can better localize the varices, and then we can go for the ligation and clipping. There are other sclerosant which we can use to stop the bleeding, like the ethanol. In majority of the cases, the varices are in the esophagus, but in minority of the cases, varices can be in the stomach. They are, in a minority of the cases, they are in the stomach, but if they are in the stomach, they are very difficult to manage, because they are very difficult to put a clip on, because they are located on the posterior surface of the lesser curvature of the stomach. Then endoscope is passed down to the stomach and down to the duodenum. We try to look for the gastric ulcers there. We try to look for the bleeding vessel in the stomach or in the duodenum. We do injection adrenaline to stop or minimize the bleeding as a vasoconstriction. Then we can better localize it. Again, we either ligate this bleeding source, or we put a clip on it. So this is what we do. This is how we do it with the help of the endoscope. Now, endoscopy is not done just once. There are chances that the person who's doing it, because this is a operator or procedure dependent procedure, this very much depends upon what is the experience of the person who's carrying out these things. So if the person is not fully successful in ligating or putting a clip on the source of the bleeding, the same endoscopy can be performed after 48 hours or after a week. So this is can be a 2-step or 3-step procedure. So the final part of the management of the upper GI bleed is the endoscopy or EGD. Then there is another form of the endoscopy which is done, which we call the capsule endoscopy. But that is more of a diagnosis rather than management, because capsule endoscopy was once hyped, but now it is not as famous. So the major thing is to go for the EGD or endoscopy to localize the source of the bleeding and to put a clip on it or put a band on it. But if it fails, if endoscopy fails, either to stop the bleed, or there is some surgical indication. There is some surgical indication. So in those patients where either the process of endoscopy doesn't stop the bleeding and patient may get hemodynamically unstable, or there are indication for the surgery, or you have tried angiographic embolization but bleeding is not able to be localized, then you go for the surgery. What are the surgical options then? Because family should be explained and there should be a surgeon handy for these procedures. In the management, the surgical options are for upper GI bleed are: number one, it can be proximal gastric vagotomy. You just cut the 10th nerve. That will actually help to control the bleeding source. It can be truncal vagotomy. It can be truncal vagotomy plus drainage. It can be truncal vagotomy plus enterectomy. Billroth 1 and Billroth 2. Billroth 1 and Billroth 2. And it can be truncal vagotomy and enterectomy, which we call the Roux and Y procedure. So if the endoscopy fails, then we can go for the surgical options, which are the proximal gastric vagotomy, truncal vagotomy plus drainage, truncal vagotomy plus enterectomy, Billroth 1 and Billroth 2, truncal vagotomy and enterectomy, Roux procedure. But and also in the surgical option, in these options of the endoscopy, we have heater probe and we have the laser probe option. We can coagulate the source of the bleeding or the bleeding vessel after it is being localized. So these topics are actually detailed one, but it's not important to go into the detail at this point in time in this lecture or in this video, because this is just about the upper GI bleed. Otherwise, when we pass the endoscope, we can actually use the heater probe or other organ laser photocoagulation. So the aim is to coagulate the artery to stop the bleeding. We can use the ligation procedure to stop the bleeding. We can also use the endoclips. We can use the clips, metal clips, to just stop the bleeding. But endoscopy should be performed after even 2 weeks, just to look at the status of the clips and the ligations. Thirdly, this is very important that those patients who have no decompensated liver disease, their endoscopy should be performed every 2 years to check the presence or absence of the esophageal varices before time. And those patients who have decompensated liver disease, their endoscopy should be performed every yearly. In the medical management, we can use the beta blockers to decrease the heart rate. We can use the non-cardioselective beta blocker like the propranolol in a dose of 80 to 160 milligram per day in a divided doses. We can also use the corvidolol to actually decrease the heart rate in those cases who have got the portal hypertension, because beta blocker use is very important in these patients. It does avoid the esophageal varices rupture in these patients because of the lowering of the blood heart rate and we can there is also debate about the use of the nitrate, but it is not as important as the use of the beta blockers. But in the nitrate option, we have isosorbide dinitrate in these patients. So there are so many options which can be used in these patients. They should be advised not to use the non-steroidal anti-inflammatory drugs. I hope it covers a little bit about this topic and it will be of some help.